Truth about dismissal of EDS. EDS is a incurable genetic disease, and women are constantly dismissed. This video is about the consequences of that and the realities of what it means and the impacts it has on these tens of thousands of young women around the world that are constantly dismissed and not believed for their pain. The primary barrier most women with EDS report to getting care and diagnosed is their primary care doctor just completely denying and dismissing, labeling them as somaticizers or psychogenic. And a portion of them get institutionalized. Another portion of them get labeled with anxiety, depression, all of these psychological conditions. So men are 66% of them get diagnosed within 11 months when they think they have EDS and are trying to get diagnosed. Women is like less than 44%. The study by Velasco in the last couple of years estimated that the potential unaliving rate in women with EDS is as high as 1 in 3. And the updated numbers on the prevalence of EDS is 6 in 5,000 now is the new numbers. So it's not as rare as they say it is. How many of you out there have this? You're watching this video. It's a lot more common than people think. Institutional gaslighting, invalidating of patients. And this literally leads to these women like with no other choice. And we're talking about EDS is a condition with unbelievable pain. Musculoskeletal pain is 10 out of 10. This is one of the most brutally painful conditions in the world. And not to even mention the fatigue, the watching the world go on around you while you're cursed with this disease that's incurable, it's genetic, it's lifelong. You need the highest level of care, and you can't even get your one doctor who's supposed to be the person helping you to believe you, and they're literally dismissing you. It's no wonder that these numbers are as high as 1 in 3. This is just me advocating, believe patients. There's so much literature to support that if someone's like reporting they have a condition that regardless of if you believe them or not, they still deserve care. I'll quote Dr. Solomon Liao, palliative care doctor who treats EDS patients, one of the most accomplished and published palliative care doctors in the world. He argues that a patient's self-report is the gold standard. The clinician spends time trying to figure out if a patient is drug seeking or faking. They are missing the clinical goal of relieving suffering, which is the goal. The whole person approach. He often mentions that pseudo-addiction, which is where a patient acts out because their pain is undertreated, is frequently mistaken for faking or seeking. Right to relief. Dr. Lau supports the ethical stance that it is better to treat someone who might be exaggerating than to leave a patient in agony because you didn't believe them. The patient's self-report is the gold standard. This is from one of the world-leading palliative care doctors who's very published. This is not an opinion. This is not a channel that is opinion. Visible Illness is a channel where we review literature and take that literature and put it into visuals and language that is easy for anyone to understand. This is a peer-reviewed published literature channel. Okay? So I just want to make that very clear. You deserve to be believed and you deserve to be treated. So some major problems EDS patients face is like getting referred for physical therapy or getting referred to pain management to interventional pain management. So interventional pain management is where they like inject you with needles and stuff, which can always causes way, way more harm to EDS patients than good. And then the physical therapy causes unbelievable harm. So this like aggressive physical therapy, this happened to my partner Clover. I always link her fundraiser in our description. I'm actively trying to get her care. She got injured by her doctors repeatedly. They were like trying to do chiropractic. The chiropractor bent her way too far, injured her. They were having her do stretch bands. If she had gotten proper care without getting damaged from physical therapy, she might not have had to have this front rib resection, scalenectomy surgery, and be in the condition she's in now. It's very tragic, and it's really messed up that so many young women are getting referred to physical therapy and to interventional pain management where they inject you with needles and hurt you even more. So this is a graph showing how this is called the Pentad patient. You have EDS, POTS, MCAS, secondary cranial cervical instability, and intracranial hypertension. So it's the cranial cervical instability that's at the center, And then you get in the center is CRPS. That is a hypersensitization to pain. And you also can develop secondary ME/CFS as well. The essential like mechanical thing that's going on is an accumulation of microtears, because like with EDS, you're too stretchy, right? This constant microtear accumulation, and then it causes this nociceptive signal cascade where you basically fry your nerves. They get damaged from constantly firing nonstop, and your body's constantly in overdrive, and your endocrine system is in overload. So you're getting jumped with adrenaline all the time. All this causes irreparable damage to your body, and it drives disease. You develop all these secondary diseases from this. And then things like physical therapy, not getting pharmacological treatment of your symptoms aren't getting managed, and then you get worse and keep developing all these secondary diseases. And a lot of people end up with full-blown ME/CFS, bedridden. This is where palliative care comes in, pharmacological management of symptoms, a full holistic approach. So this is literally how like ketamine treatment with palliative care has even saved the lives of EDS patients. And there was one study published by Dr. Lau where he treated this patient with an inpatient, like week-long ketamine infusion. And she was able to walk for the first time in years and cut her opioid intake in half. Ketamine actually has neurogenic properties. It helps regrow nerves, is neuroprotective. It helps with neuroinflammation. There's so much that palliative care can do to treat EDS patients. I actually want to take a minute just to explain like the exact biological components of like why ketamine was able to, like, by a palliative care doctor, Dr. Solomon Lau was able to treat a patient who was bedridden, is in a wheelchair, with ketamine therapy, and she was able to walk afterwards. So this is like how it works. Why ketamine? And the literature supports this. So the constant state of hypersensitization and like irritation in your body with EDS causes this overreactive state. Even with active palliative care, they were on like hundreds of milligrams of morphine a day, on gabapentin, baclofen, all of these normal medications that are normal for an EDS patient to take. Even with all of these opioids, she was still in pain. So he was actually able to treat her with ketamine, IV, inpatient. It's called continuous nociceptive trauma from daily joint subluxations. It's a process called central sensitization. These receptors lock into a hyperreactive state, flooding the brain with extreme pain signals. Ketamine enters the system specifically as a non-competitive NMDA receptor antagonist. By blocking these specific receptors, the ketamine forces them to regress back into a dormant state, cutting off the propagation of the pain signal. Dr. Liao executed this mechanism at an extreme level. He placed a patient in a 7-day inpatient in the hospital for the ketamine midazolam solution, tapered off the opioids, tapered on the ketamine, but he did this like high dose, like 7-day inpatient ketamine regimen, and it literally rewired her constant pain activation. And it didn't cure her, but allowed her to walk for the first time in years. Her baseline pain was from an 8 down to a 3 when she woke up. Incredible, miraculous palliative care for EDS. It's literally a miracle, but it's an aggressive daily maintenance regimen. So she still was off-label daily ketamine. She was taking gabapentin, baclofen. She was still taking opiates, just not as much as she was. And she was doing twice weekly IV ketamine infusions still. A lot less meds than she was before, but she still is taking a massive amount of medications. And EDS patients, fentanyl and oxymorphone are the only two opioids that don't activate mast cell activation. So all the other opioids cause really bad mast cell activation. And you probably know this as an EDS patient. They'll give you meds and they make you feel so much worse. It's really only those specific ones, but they're so highly regulated and there's such a bad like stigma to them. It's super tragic. Again, I just want to say this is heavily supported by the literature, but this all proves that you can treat EDS with intense pharmacological pain management and palliative care. So if this is a miracle story with all the literature to support it, so why is it so hard to get palliative care with EDS now? Ever since the opioid epidemic in the reform from like 2014 and 2016, they came in and shut all of the pain clinics down across the country. Private equity came in and started investing in things like buprenorphine and all of these like interventional pain treatments and all of these like non-opioid treatments. So it's like all of a sudden billions of dollars rush into all of the non-opioid pain management stuff, which is horrible for EDS patients. All of the pain management clinics got heavily regulated, and basically all the EDS patients now exist in what's called the palliative gap, where they were getting care before and now they're not. And it's super tragic, but that doesn't mean we should stop advocating for this. The paradoxical need for EDS patients, why can they take 4, 5, 10 times as much meds as the average person? Genetic variations common in EDS populations cause a hyper rapid opioid metabolization. So this is like one of the first things that makes it really difficult for EDS patients to get proper pain management care, because they need 4 times as much the dose of the average person. And you know this as an EDS patient. You'll take 4 times as much as what someone else was, and it doesn't even do anything for you, and someone else will just get knocked out. But this is the reality. And those practitioners, providers that are educated on this know this well. In the literature, there's mountains of literature to support this. So this isn't an opinion. It's not controversial. It's not radical. It's well documented and well. The literature says otherwise. We have hard evidence of this. But these patients require massive pharmacological doses to meet the basic pharmacological needs of what any other basic patients need. So around 2010, they had the 90 milligram morphine equivalent FDA announcement, and the DEA started enforcing all this regulation regarding opioids and pain management. EDS patients are like up at the 250 milligram equivalent, but now the daily limit is 90 milligrams. So this is just crazy, especially for the patients that were getting treatment before 2014. They like would get their medications literally cut off. So EDS patients are like the 250 morphine milligram equivalent on average, but the daily cap is at 90. So just the basic needs of EDS patients is now getting flagged through their like automated care system as drug seeking or criminal. So literally the DEA is like going around and like enforcing all of this regulation now, and doctors are completely risk averse and don't want nothing to do with it. And that's why people like Dr. Solomon Lau, unfortunately, no longer treat EDS patients. It's very sad. It doesn't mean no one out there though isn't treating EDS patients. I literally called USCCAC and asked if they would do an assessment for EDS, and they said yes. I'll let you guys know what we find. So the DEA even has caps on, they're called aggregate production quotas. That's how much manufacturers can create in a year. And there's also caps on how much opioids a pharmacy can carry. So even if you find a pain management doctor or a palliative to do pharmacological management, it's almost impossible to find a pharmacy that can even fill how much opioids you need, because they only have so much for the month. So this is the harsh reality of what we're facing now with palliative care with EDS patients. It's a hostile architecture and automated denials from insurance, DEA regulations, and outright gaslighting and denial of care. There is still the right to pain management. There's still legal protections in some states. In some states, you have a better time, like Minnesota and Rhode Island. In general, you have a better chance of getting palliative care, at least pain management, pharmacological management, than other states. Minnesota even has this state code that has protections against like pain management doctors. They literally can't be prosecuted by DEA. Also, like when you use the ICD code for palliative care, you have protection. If you're going to get pharmacological management for EDS, palliative care is really the only path forward that's safe. If you're someone that's struggling with this, that is in unbelievable pain and no one will believe you, just know that I believe you. The patient reported symptoms is the gold standard. You're valid. You deserve care. And I hope by creating these videos and our resources at Visible Illness, I hope they can help you on your journey to get the care you deserve. I see you, I believe you, and I believe in you.